Bismillah. Assalamu alaikum. Good morning, everyone. It's my pleasure to introduce Dr. Ala Hawil. Dr. Ala is a consultant psychiatrist at the American Center of Neuropsychiatry, Abu Dhabi. He earned his medical degree from Asyut University in Egypt and then completed diploma degree in neurology and psychiatry from Alexandria University. Dr. Ala has more than 35 years of experience in psychiatry, out of which 12 years were in UK prior to moving to Abu Dhabi. He was elected as member of the Royal College of Psychiatrists in UK in 2002 and worked as a locum psychiatrist in the NHS from 2003 until 2007. Prior to this, he worked at St. Andrew's Hospital in Northampton, the largest tertiary referral hospital in UK, as associate specialist psychiatrist. In Abu Dhabi, Dr. Hawil worked as a consultant psychiatrist and was the chair of Forensic Psychiatry Board, as well as the associate director of residency program from 2007 to 2021 at the SKMC. He served as expert witness for Abu Dhabi judicial system for more than 12 years. In 2021, he moved from SKMC to the ACPN. Dr. Hawil has extensive experience in general adult psychiatry, forensic psychiatry, and psychiatry of learning disabilities in both inpatient and outpatient setting. He presented at numerous national and international conferences in addition to being involved in undergraduate and postgraduate medical educations. I personally enjoy his talks, and I hope you will do so. Dr. Hawil will talk about dilemma, legal and ethical dilemma in psychiatry, which is a very challenging topic in psychiatry. We all hear about Mental Health Act, but there is no Ortho Health Act or Cardiology Health Act or whatever. This may give an impression about how this topic is very challenging. Please join me to welcome Dr. Ala Hawil. Thank you.
Thank you very much, Dr. Mansour, for your kind introduction. The subject for today is about the legal and ethical dilemmas in psychiatry. I will try my best to put it in a way which make it simple, understandable, and try to present after a little while a number of clinical cases where ethical dilemma and legal dilemmas were encountered, and we will try to share kind of views and kind of opinions about each of these cases. But we need to understand that maybe we're not going to conclude in every case what would be the best course of action. I think the aim of this presentation is just to give you the sense and the feel of how can it be difficult, how difficult it can be to face situations where ethical issues and legal issues can be in place. I'm sure you would expect there are differences between laws of different countries. Every country has its own laws. Some countries, they have Mental Health Act. Mental Health Acts can be different from a country to another. There are certain kind of regulations like Mental Capacity Act, for example, in certain countries with certain specifications. So every psychiatrist will have to be aware with the country he practices in about the regulations, the laws, mental health laws, etc. When we're talking about the two principles of approaches to ethics in psychiatry, we have what we call the duty-based approach and utilitarianism approach. When we say the ethics, we have to look into 4 areas. Autonomy, usually the patient will have to be deciding on him or herself. Beneficence, any intervention will have to be to the benefit of the patient. And non-maleficence, there's no harm. You cannot inflict harm to the patient. And finally, justice. Sometimes these approaches can be conflicting. For example, if you have a patient with a serious injury and he refused to receive medical treatment. So in that situation, if you look into his autonomy, hey, it's up to you, okay. But at the same time, you shouldn't be doing something to kind of deprive the patient from benefit or to allow certain harm to be there. So sometimes the situation can be conflicting between two approaches, like the usual duty-based approach and utilitarianism approach, which is a terminology usually used in ethics. And usually it means what will be the best, the big benefit and the least harm. The kind of law of maximizing the benefits and minimizing the harm. When you practice psychiatry, whether a doctor, a nurse, a social worker, a psychologist, you have usually 5 areas of law of interest to psychiatrists. What is called the common law. Just to try to understand these terms. Common law, if somebody comes to the accident emergency department with serious injury and he's having behavioral problems, confused or whatever, you need to get a blood sample or to do an x-ray, and he is not cooperative, then you may have actually to apply a certain power to give you the permission to violate his autonomy or his wish. He refuses to give you a blood sample. He does not understand what's happening. So at this point, you have to be using something. You cannot say, I'm going to use this because it is good for him, or it's bad for him, or it's my duty, this and that. We try to use certain terms because the patient may sue you and say, why did you take a blood sample from me? Because I have used the common law of necessity. So common law of necessity will derive from certain situations. People will have accumulating experiences, accumulated custom habits, and sometimes cases will come to the court and lessons will be learned from such cases. So the common law is going to be expanding, is a dynamic law. Mental capacity law. You sometimes have to make a decision. For example, somebody with dementia and he has an acute appendicitis. He doesn't want to go to hospital, for example, to be operated upon. So you may need to use something to be able to impose the treatment on him. And this usually should be the Mental Capacity Act, because you think that his mental capacity is affected by his illness to the extent that he may not be at all able to make valid decisions. And there is testing for the mental capacity, which is usually his ability to understand the intervention you propose, to retain the information of that intervention, to make a balanced kind of argument and decision, and to communicate to you clearly his wishes. So if he does not actually have these, so he will fail a test of capacity, then you may carry on against his own wishes, but usually not with the consent of his family. We believe in the modern ethics that nobody can consent for another person except in kids, where the parents can actually sign for the kids. But usually if the patient does not have the capacity to sign for himself, the doctors will have to make a decision to the best interest. Sometimes the decision is very tricky. The doctors will have to take the case to the court, for example, to be supported. So in the heart of it, you try to help the patient. You try not to violate his autonomy. You try actually to benefit and not to harm the patient. And at the same time, you don't want to be liable for legal actions against you. So you need to also to protect. And also you have to stick to the laws, regulations in your area to the maximum. Customers' habits, what is expected. You shouldn't be extremists in following certain rules which may not apply to the area, as I'm going to come to you in the cases. When we talk actually about criminal law in relation to psychiatry, this is also an area usually encountered in forensic psychiatry, where there are certain kind of obligations for the psychiatrist to make a medical report or a psychiatric report. It may comment on fitness to plead, or fitness to stand trial, or, for example, criminal responsibility, or the rest of it. So consent to treatment is in the heart of the ethics in psychiatry. Every person will have actually to accept or refuse treatments. And basically, even if the outcome is serious harm to the patient, like death or significant deterioration, if he has capacity, if he doesn't have actually a mental health issue, then you will have to respect that. You cannot actually impose, for example, surgical intervention for cancer for somebody. He doesn't want this to be done for him. He may die out of it. So in the kind of modern ethics, yes, you have to listen to what the patient says. If he has the capacity to understand, if he has actually the wisdom, and he is clearly against performing, for example, this surgical intervention. If you give treatment without the consent, you have to have a good reason. And that reason, as I mentioned earlier, should come from, if you have actually support from the common law, which usually in a situation where you have to make a decision right now. This guy is bleeding and he's not cooperative. I will have to do something to stop the bleeding. This is a common law of necessity. If you are in the ER, for example, a patient brought by the family to the ER, then he ran away, okay? Then the sub will run after him and bring him back. Under which powers? How can you do that? This is a law of necessity. This is a common law, okay? Because you cannot use capacity because he did not assess capacity. You cannot use the Mental Health Act because you did not assess his mental state. And usually the Mental Health Act, according to many legislations, cannot be done in the ER. You cannot actually do the Mental Health Act. You cannot actually apply the Mental Health Act straight away in the ER. There should be an assessment. But sometimes we can do things under a different, but we have to do something now, usually on the spot, common law. Then assess capacity or assess mental health and use the Mental Health Act or do an assessment and rest of it. You can't give treatment or intervention or investigation under authorization by a court in certain situations. Advanced treat statements, if somebody has capacity, for example, we come across a few cases, he said that he has a bipolar mood disorder, for example. He said clearly, if I become manic, please don't give me lithium, and give written statements. I don't want lithium at all. So you have to be obliged to stick to that unless you have an evidence, and then the case will have to go to the court. Evidence that only lithium can help this patient. But usually you will be in trouble if you give the treatment the patient stated clearly in a previous time when he was in remission, when he had the capacity, that he doesn't want lithium to be given to him, for example, which is a treatment for bipolar. So capacity to make treatment decisions, it's a legal concept. Usually the norm is every adult for us has a full capacity to decide for himself. And capacity is usually a balance of probabilities. You can't say 100% this has capacity or this doesn't have capacity, but usually you have bits and pieces here and there, and you have to conclude at the end of it, on balance of probabilities, you decided that this patient does not have capacity. He may have certain capacity in certain areas, lack of capacity, but in relation to this particular situation. And usually people may have capacity regarding one situation and not to another situation. And I will see the example, for example, somebody who got schizophrenia, for example, and he thinks that the doctors are going to kill him. So he does not clearly have capacity on refusing medical psychiatric treatment for his case, but it is clearly if it is about, for example, surgical intervention in his case, which is not related to his mental illness, he would have capacity to refuse this surgical intervention. But when it comes to mental illness, he may not be seen as having capacity in that situation. But usually we have the Mental Health Act, which we use to give treatment against the will of a patient, not the Mental Capacity Act. Capacity can be extended, and I'm sure many of us, I'm sure all my colleagues from SKMC, Dr. Amani and Dr. Sheikha, people who work in the medical board, they know that we get frequently requests to assess the capacity for somebody to manage his or her own affairs. And usually have to come with a statement, he is having capacity or he doesn't have capacity to manage his own affairs. And there is a test for that usually we have to apply. Again, this is a common law, basically. So the common law, as I said earlier, is derived from customs, experiences, accumulating evidence, seeing cases, and many actually situations will be added to the common law with reference. Sometimes we say, yes, I'm going to do this under the common law because in that case in 2016, the judge so-and-so made that decision that this is a necessity situation and this will have to be done, and it has been done and has been accepted by the court. So you can actually provide evidence. Civil law, understandably, psychiatrists may have to personal injury, for example, compensation. Like, for example, somebody who suffered from PTSD because of a car accident, seek compensation. You may have to be advised to give a decision, an opinion on that. Fitness to drive, is this somebody fit to drive because of his mental illness or not? The power of attorney and receivership in the Western countries, for example, the UK, the ability for somebody to manage his own affairs and the need to appoint somebody to work on his behalf. Marriage, again, like marriage cannot be, contract cannot be done by a person on behalf of somebody else. This is the usual. Okay, if he does not have capacity to sign for a marriage, the marriage contract shouldn't be valid. This is in most places, okay? So nobody can say, for example, I will sign on behalf of my son to get married to this lady. This shouldn't be the case, but it happens, it happens. These are common areas. Negligence, sometimes psychiatrists will actually be having dilemmas. Did he do enough for this particular patient? Misuse of psychiatry is a common long-term ethical dilemma in psychiatry. You remember the era of the Soviet Union and where they've been using psychiatry to get politicians into confinement because they suggest that they are mentally ill because they don't follow the norm or the rules both by authorities in the society. So it has been used a lot, unfortunately, in the past. Hopefully, not much nowadays. Misuse of psychiatry, even during the recent, I have to admit that I recover from a gastroenteritis, so I'm trying my best to be functioning as much as I can today. Misuse of psychiatry, there has been a big fight between the Royal College of Psychiatrists and the government in the UK. They wanted to add a classification for people with severe and dangerous personality disorder as a diagnostic category, and consequently they asked that if we can detain them under the Mental Health Act, although or despite the fact that many of them have not committed offenses yet. If somebody committed an offense, we may think about if does he have a mental illness, psychopathic personality, may be treated in secure hospitals with various programs. But if a person doesn't commit an offense and you want to detain him for the protection of the society under the Mental Health Act, so the Royal College of Psychiatrists objected to that, and finally that kind of rule has not been passed, because they thought they are misusing the psychiatry to try to label some people of having dangerous personality disorders so they can stay in forensic units for good under the Mental Health Act for treatment of personality disorder if it's treatable and protection of society. Confidentiality, patient-doctor relationship, usually when there is a violation of the nature of this relationship, especially in psychiatry, psychotherapy, therapists may get very close to the patient, transference, counter-transference. In many cases, the case will have to be brought to the ethical part, and by law, you shouldn't have a relationship with your patient, basically, whether you are a psychiatrist, psychologist, or a nurse. This is definitely against the law. Compulsory treatment, definitely very much a part of our job. children care. Somebody, for example, we get asked in the medical board frequently, is this lady capable of looking after her children, for example? And we will examine if this lady has mental illness, which would make it really difficult for her to take that responsibility. We can actually advise the court. Research, usually there's ethical issues in research. Like, for example, you can treat somebody with severe depression with placebo, for example. People will say, no, you cannot do that. Or you continue to carry on a trial, although the evidence is clear that the people who had such a treatment, they are relapsing. So you need to stop the trial. You can't just proceed endlessly. And the capacity assessment, definitely, psychiatrists can be called to give advice in the general hospital about capacity. Every doctor should know how to assess capacity, but particular psychiatrists, they have specific expertise, or they are expected to have specific expertise, and they have actually to advise on if somebody has a capacity when it comes to signing a consent form for the operation. When signing a consent form, the form would have to be what we call informed consent. Somebody with no ability to understand the benefits or the side effects or the value or the details of the intervention cannot be taking what we call informed consent. If somebody under pressure, as I'm going to come with one of the cases, and he had to sign a consent, you can say this is a valid consent. Like his family said, for example, either you sign or you're going to be put in, you be confined in a dark room in the house. Then he will have to sign for admission, for example. That's not actually a valid informed consent. Confidentiality, again, it is in the heart of the ethics in medical practice. And in many countries like the UK, for example, they have a Data Protection Act, confidentiality. Every organization, when we used to work in SKMC, every organization, they have to sign about leakage of information, who should know and who shouldn't know, how can you pass information to member of the family, and should you or you shouldn't. Sometimes you have to break confidentiality in certain situations, and this is, again, an ethical dilemma. Like, for example, somebody was diagnosed with AIDS, and you know that he's sexually active and has multiple partners, has personality problems or whatever. Then you may have obligations to report about this patient because he's just putting people at risk. Unfitness to drive. If you know that your patient has visual hallucinations non-stop, or he has, for example, brain damage because of car accident, and he's still driving, you may have to report. Suspicion of child abuse definitely is one of the areas. Order of a court. If a court ordered you to give detailed medical report, then you have to provide the court as long as the court is trying to reach a just decision regarding this patient. If there is a concern or harm to a third party, you knew about, you're going to come in a minute, a patient, for example, has delusional jealousy, and he is telling you, I'm going to go now and kill this bad woman. Then you have actually then to inform the wife or to do something to prevent this harm from happening if you are sure about this. We'll go into clinical scenarios. Then we'll have a discussion between ourselves here. These are true scenarios. Each scenario has been encountered at least by myself or my colleagues, I'm sure by many others. Mr. M is a 40-year-old man presented to our outpatient clinic, accompanied by his brothers. He demonstrated clear presentation of delusional jealousy and already has been violent to his wife, resulting in her leaving to her family house. He made threats of taking revenge and harming her. His brothers did not agree of his admission to an acute psychiatric unit. So what will be your next course of action? Inform the police, contact the wife immediately, admit the patient against his own will and without the consent of his family. Can you do that here? Let the patient and the family leave. They refused. Okay, end of the story. None of the above. So what do we think? We need volunteers, okay? Number one, inform the police. Yeah. What's good about it? What's bad?
Involve the legal departments
Okay.
to be officially and legal.
Do you want to inform the police or the legal department in the hospital?
Inform the police.
The police. The good thing about it, you're going to protect the wife. But the bad thing about it, you would lose a chance to engage and work with this particular patient. You become cross with the family and cross with the patient in future situations. They will never be able to have a working alliance with you. Okay, any other thoughts?
I think if you have a mental health act, the most appropriate choice will be to admit the patient against his own will and without the consent of his family. And I think this is one of the scenarios that actually mandate that we have mental health acts, which unfortunately we do not have in Bahrain. But I think in UAE you have a mental health act. So,
I mean, the
but I
kind
don't
of
know whether it is
the mental health
applied or
act
not.
is not yet what we call
Implemented.
the kind of اللائحة التنفيذية still actually not in place. The sort of forms, the admission forms, and this and that is not yet in place. Do you think in our culture can we go against the family wishes? Do you think this is possible?
No. Actually, we are in Bahrain facing the same situation. Without mental health act, you cannot actually, and unfortunately, we only do consent of the family. In this scenario, for example, what we do is we try to involve other parties. For example, if there is a father is available, we call the father, we explain to him the risk.
So why you do that?
And we even let them all sign against medical advice. They made them all, including
So
the
why
patient
do
who
you-
does not have,
why do you contact
just
the
to
grandfather?
protect what, yeah,
The
to improve
father.
actually the chance that, because sometimes if we know that there will be even a conflict within the family themselves about how to deal with the situation. And if you explain the risk to the father, who is
Good.
actually in our like rule, he is the
So
one who
this
has
is another way
the
to do
next.
it. Yeah, this is another way to do it. Just try to actually reach an agreement here.
True.
It's not about just managing the risk and walk away. It's a bit more complicated than this. Okay, you decided to spend more time with the patient to persuade him to accept medication, which is I think what you need to do to help reduce his stress. Tell him that, for example, you just need to accept this medication, help your anxiety. You don't have to tell you are deluded, you have delusions, your wife is a good woman. You don't have to do that. You also try to convince the brothers to support the treatment plan. So you try to reach some sort of an agreement. The patient couldn't be convinced, refused any treatment, and family did not like to stigmatize him with a diagnosis and treatment for mental illness. So what is your next course of action? Inform the police again, warn the wife and her family, break confidentiality, start the process of using the Mental Health Act to detain the patient with the help of the police. Okay, this is it. Suppose that we have a Mental Health Act in place and we can actually use it straight away. Discuss the matter with your clinical director or lead clinician. All right. I think you have to make a decision yourself. Contact the hospital legal advisor for advice. Okay, so these are possible scenarios. Again, we'll come to the first. It's good actually to try to get the patient to agree to take medication, and maybe you can find a way of making sure this lady is safe by kind of her family protecting her. You agreed with the patient to come to see you in the outpatient clinic every week, for example. He actually he's received a small dose of an antipsychotic as an anti-anxiety, and he accepted help for alcohol misuse problem, which has been behind his delusional jealousy, for example. The family accepted that they will keep him separated from his wife for the time being or for her safety. So what is your next course of action? You reached that point. Accept the current plan? Yes or no? Still warn the wife and her family? I'm worried. Maybe he's going to do something about his wife. Inform the police to avoid any legal liability? I just inform the police and just keep a peace of mind. Refer to forensic psychiatrists. In UK, for example, you sometimes can refer to the forensic psychiatrist. This is actually not a general adult psychiatric case now. It is a need for more expertise. And then you wash your hand of that case. Sometimes you can do that, but not here, I believe. Ask the patient for consent so that you can speak to his wife for more information. That's a very good way of doing it. Can I just need to talk to your wife? I'll find out more. I'll see why this is happening. Don't take the side of the wife or the side of. I need to know what is happening, basically, and feel very sorry about what's happening if this is actually the case. I need to talk to your wife. Can you allow me to do that, please? Can I have her number? Blah, blah, blah. You talk to the wife. And the wife, I'm sure that she knows about what's happening, and she can tell you, for example, no, doctor, he's not going to do anything. He's just threatening. I'm the house of my family. Please try to engage him in treatment, and this will be much better, blah, 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 blah. Ask the patient for consent so that you can speak to his wife. Refer for marital therapy. I wouldn't say this does not apply in that situation. Refer to social worker in your team and share information with her. This is again about, can you disclose this information to the social worker? For example, some system, they say you cannot share information unless there is a necessity. And you have to, is the social worker going to do something really in the management or not? Require a signed written document from his brothers indicating the responsibility in case harm happens to the patient or others. What do you think of this idea? Dr. Muaz, أهلا, ازيك?
Assalamu alaikum. Shukran, Dr. Ala. First of all, the case is very interesting, and the delusional disorder, the problem about morbid jealousy, that the family see the patients as normal as he is. And if they're far away from the topic between him and his wife, they won't support you much into admission and treatment. We had a scenario a couple of weeks ago, and it was very difficult to convince the family that he's sick to start with. But having the delusional disorder as a confirmed diagnosis with the alcohol misuse and the threat that he made, I think it's very important to warn the wife and her family. Whatever is the scenario, even if you're going to admit the patients or if you gonna follow up with him in outpatient basis.
Okay, I think this is quite sensible. As I said, we may not have to conclude here. I'm just giving you the sense of the difficulty here. All these actions could be seen as good. I personally believe in trying everything to get the patient on my side first, then the family on my side, using as a resource like talk with the grandfather, trying to get the patient engaged without telling him that I disagree with you, that your wife is unfaithful or whatever. Try to get everybody on board, try to make alliance, try to treat, and if you admit, you try to admit with the consent of the patient as much as you can. But if you, for example, inform the police and the family came and say, this is a scandal for us, you did this and this is a complaint, you can always defend yourself. But what I'm trying to say here is not actually about just you defending yourself. It's just about doing the right thing for the patient, he's a patient, for the wife, for the family. The right thing, the safety should be there, confidentiality should be there, autonomy can be there. So this is a situation where you are all over the place with these things, and you have to use your wisdom, and you have to be realistic about such a situation. Do you think if you informed the police, Dr. Muaz, what do you expect the police to do? Take him to hospital, right? He will be staying in hospital, then he decided to divorce his wife, okay? Then we called it, yes, he has capacity to divorce. No, he doesn't have capacity to divorce his wife. Situation escalated between you and the family. The family said that we're not going to get in touch with mental health services. Those people destroyed the house of my brother, this and that. It's not always easy, but you have to use the least damaging, non-beneficence, maleficence, these difficult terms. So you have to benefit and not to harm as much as possible. We need to conclude here, okay? One last comment?
Yeah, I will just add a challenging situation, because actually I have a patient with morbid jealousy. And he did not actually have a high risk of violence toward the wife, but he was interrogating her all the time, and she became even more depressed. And when they came to me in the first time, I told him, that what you have is a mental illness and you need to be treated for that. But he refused, as my colleague said. And I explained to the wife about the nature of the illness.
They came together.
They came together, yes.
Okay.
Then actually he disappeared. He came to me after 2 years again. And the condition was a little bit more worse. She became more depressed, more marital disharmony and conflict. The challenge here is what? I told her that actually not only that he does not have insight and he is accepting a treatment, even the percentage that he will respond to treatment is 50%. So there is a chance that he responds and there is a chance that he may not respond. So she decided actually to raise a case for divorce against him. Mm-hmm. And here you may receive from the judge himself a question whether really the husband is having a mental illness and this mental illness is treatable or not, to justify actually her
divorce
question. Yeah. So how do you respond in this case?
Are you asking me about?
Yes. We are sharing actually what.
To be honest, geographical separation can be, if the delusional jealousy is a delusional jealousy, not because of substance, not because of alcohol, it's sometimes very difficult to treat. And the reality is, in certain situations, we advise him to live in Al Ain, wife live in Ras Al Khaimah, and he shouldn't get nearby and divorce. Sometimes geographical separation is the only answer here. And believe me, when the divorce happens, he will forget about her. When he gets married again, he is likely to develop the same thing. This is the issue. Very quickly, we had a sad situation. If you remember, Dr. Amani, he was a patient, basically admitted to one of the hospitals, governmental hospitals, because of delusional jealousy, and basically the wife pleaded to the treating team to discharge him. He said that my husband is a good man. He's just not right in the head right now. And she said that I will give him the medication. Give me something I can put it in his juice. Then they gave her olanzapine velutab. He was discharged from the hospital. She gave him the velutab. He drank it. He felt sleepy. Then he concluded that he is now put to sleep for her partner to come in. Then he stabbed her to death. Got to the medical board. You remember this case, Dr. Amani? I don't know if you remember or not. And yeah, this is a very sad situation. Can we blame the doctor? Maybe. If we were there, we would have done something different. We should have done anyway. So sometimes you cannot actually get it all right. Okay, scenario 2. All these are true scenarios. 20-year-old lady diagnosed with depression, borderline personality disorder, background history of physical and sexual abuse by a close relative. Patient mother is under treatment for depression in the same department and has a difficult relationship with the patient. Self-harm escalated for the patient, and the patient made suicidal gestures. Concerns have been raised by the treating psychologist. You treat her, the psychologist is treating her, another psychiatrist is treating her mother within the same department. The concern raised by the psychologist, the mother keeps asking for updates and sharing information. The mother wanted to be able to safely manage the lady at home. Patient refused to let the mother have access to any information about diagnosis and about treatment. The mother threatened to complain against you and the psychologist for not doing enough to protect the daughter. What will be your next course of action? You just informed by a psychologist about the situation. You are the treating psychiatrist for this lady. There's another colleague treating the mother for depression. He refused any contact with the mother. No way, I can't contact the mother. Share information with the mother to protect the patient, including information about her suicidal and self-harm threats and the plans. How about confidentiality? Talk to the psychiatrist who treats the mother depression, exchange views about the case. Can you do that? Can he share with you information about the mother? You're not treating her. None of the above. Okay, volunteers. Maybe there is no right and wrong answer, but what do you think you should do here? Any of this seems to be sound. Okay, I would say there's nothing right about this answer. The patient finally agreed for you to talk to the mother. You actually, I talked to the patient. I said, can we talk to the mother, but without disclosing, just to explain to her where we're coming from. Because she's very angry and she's very upset. She has the right to be upset and angry. I believe if you apply the the ethical, he should not disclose to you information about his patient because she is not your patient. Okay, she is his patient. Maybe the mother would become very furious. Why did you disclose this information to Dr. Hawil? He's not my doctor. How about if Dr. Hawil tells my daughter about what you said about me? So, in reality, we cannot do that. If we apply definitely the ethical codes. So she agreed for me to talk to the mother, which I did, but without disclosing any information. I explained to the mother that the patient has the right to keep her case confidential, but also I reassured that I will share information, maybe only if I feel there is serious risk of harm or suicide. And I given her all the resources. If something happens, she can always contact the crisis team, emergency department, crisis intervention, ambulance service, psychiatrists 24 hours a day in Sheikh Khalifa or in Al Ain or wherever. Then, okay, we agreed on that. One day, the patient just asked disclosed to her psychologist and to her therapist in one of the sessions her intention to end her life. The therapist called you at your clinic as she was very concerned. The lady was there with her. She said, I had enough. I'm going to leave here and kill myself. What would be your next course of action? Inform the police? Talk to the mother and ask her to come to the clinic immediately? Arrange for immediate assessment by the duty psychiatrist or yourself, if possible? I mean Mental Health Act assessment, although this is still not applying here. Let the patient leave as her threats in previous sessions prove to be false, for example. Would you do that?
That would be the safest. That would be the safest and most likely.
So,
You need to assess her yourself and decide. And if you cannot, you can advise her to be
okay, I've seen the patient. I convinced her, I said about informal admission to the hospital. I said, we have a right to admit you against your own will. We can communicate with the police. We don't want to escalate the situation. And we will get you admitted. And she agreed. Mother actually been informed about the admission. And what would be your next course of action? This is, agree with the plan. Or no, I have to insist on the Mental Health Act to admit her because she may change her mind. So what happens if she changes her mind in hospital? She wants to leave, for example. You can apply the Mental Health Act at that moment. Yeah. You can apply even the common law. If, for example, in the ER doing the admission, then she wanted to run away. Then you apply the common law to bring her back in. Okay, so the least restrictive, this is the point I am after. But sometimes you have to take some risk or think about the consequences of your actions, whether they are going to be overall helpful or harmful. Okay, so this is a real case from the UK. He's a gentleman, 23 years old gentleman with established diagnosis of antisocial personality disorder, borderline personality disorder. He has a long-term history of serious self-harm behavior. He has a history of recurrent admission to psychiatric hospital, both informally and under the Mental Health Act. In 2012, Mr. R was convicted of sexual assault on staff nurse, and he was sentenced to 5 years in prison. In 2013, he embraced the religion of Jehovah's Witnesses, cannot receive blood, while in prison. And in February 2014, he signed advanced decisions, document under the Mental Capacity Act. Under the Mental Health Capacity Act, you can actually write advanced directives that I shouldn't be given blood even if I bleed to death. that shouldn't receive any blood transfusion because of his faith. In April 2014, he slashed his brachial artery in the elbow region. Consequently, it was advised that he needed blood transfusion. He refused blood transfusion. He was managed conservatively. Due to the escalation of his self-harm behavior, he was transferred for admission in a secure hospital under Section 47 and 49 of the Mental Health Act. This is the section in England and Wales. What happened? He tried to open up the wounds and has had to be restrained to prevent him accessing the wound, and that restraint is a kind of medical intervention. You should put actually a term to say, is it under the common law or under Mental Health Act or whatever, to prevent him from injuring himself. He continued to refuse blood transfusion under any circumstances, and his treating team were concerned that he may cause himself to bleed to death. This would be a management dilemma, as blood transfusion cannot be an option. So what do you think his treating psychiatrist should do in case he injured himself and needed blood transfusion? Not to consider blood transfusion because of advance directive, not to consider blood transfusion as his face doesn't allow him. He is detained under section of the Mental Health Act, and his physical condition, in case he suffered serious bleeding, would be a symptom of his disorder, because self-harm is about a borderline personality disorder. So you have here a situation, normally speaking, you cannot give medical treatment under the Mental Health Act. And this will come to the country soon. You cannot give medical treatment, but you give psychiatric treatments. You cannot give medical treatment under the Mental Health Act, basically. But you can give it under the Mental Capacity Act. If you give it under the Mental Capacity Act. Or under the Mental Health Act only if you can make a link between this treatment is likely to improve his mental health. With this, in this case, blood transfusion is likely to improve his mental health? Maybe not. It's just going to keep him alive. So, the idea about actually he has a Mental Health Act in place, so he can receive medical treatment under Section 63. In the England and Wales, I will use the section which I'm familiar with. There's a section called 63. You can give treatments like medications, antipsychotics, whatever, under various sections, ECT treatment, emergency ECT, or whatever. But if you're going to give a medical treatment, like, for example, giving blood transfusion, giving fluids, even moving the patient from the room, you have to use something. So it is Section 63. Any physical dealing with the patient or medical treatment should be under Section 63 of the Mental Health Act. Perform a capacity assessment and consider blood transfusion as an option under the Mental Capacity Act. Do you think this guy will lack capacity? Maybe not. He just has his faith, and he just doesn't want to receive blood transfusion. Whether he is manipulative or he is definitely believing in what he says, but this is a situation. Request declaration and directions from the court about the matter and the patient's right to refuse blood transfusion. I think this is what they have done. It's a very complicated situation. They cannot get a right or wrong answer here. Under capacity, he has capacity. He has advanced directives. He actually cannot be given blood transfusion under the Mental Health Act because it is not a psychiatric treatment. It's a medical treatment. And this medical treatment is not connected to the improvement in his mental health. So they cannot do that. So they did ask the court, and the decision. Do you think the court decided he can get blood transfusion under Section 63 of the Mental Health Act, i.e. considering blood transfusion a kind of medical treatment related to his mental illness? Usually, just to complicate things, if the condition, which is a self-harm, is a manifestation of the mental illness, you're not necessarily going to treat it under the Mental Health Act. You have to treat it under other powers, basically, because you are supposed to give medical treatment which is likely to treat the mental condition, not the consequences or the results of the mental condition. If somebody slashed his wrist and said, no, I don't want sutures, according to the regulations, unless he doesn't have capacity, you cannot actually go and stitch him under Mental Health Act. You cannot do that. And you cannot draw the conclusion that stitching his suture, making sutures will help him to recover from his depression, for example, or from borderline. You cannot make that connection. I think what happens, he has capacity. Okay, what happened, I think, in that case that the court said that, I think, with the advanced directives, he has capacity, he can actually refuse blood transfusion. This is actually the ethical dilemma. If you apply the rules here, autonomy, yes, too much autonomy, maybe more than should be. Beneficence, what sort of beneficence? Maybe he is following his faith, maybe God will be happy with him, according to his understanding. Non-maleficence, I think he's going to get serious harm. Maybe he would die. So these are the conflicting issues in such scenario. This is a
Dr.
case.
Ala, I believe this situation will be very difficult here because we have to deal with the family to explain to them that we cannot force him to take blood transfusion or whatever. Because again, it is like cancer patient refusing operation, even if it is necessary to save his life, but still has the mental capacity. And then the psychiatrist has to deal with the
I
furious family.
totally agree, Dr. Mansour. That's why they went to the court. The court ruled you cannot make that decision yourself in such a situation. And a place like the UK, they were going to make problems, but you have the court ruling. You cannot do that without the court. This is the issue. If we are having this case in the United Arab Emirates, I would personally give him blood transfusion. Because I cannot be wrong if I do that for the majority of the people's understanding, including the family. And if he wanted to complain against me, I think I will win the case. Because everybody would think that it's not good if you leave this guy die because of his injuries. Because his injuries are related to his mental illness.
And they can't be justified by the common health law?
The common law, usually, Dr. Mansour, should apply only in a very small situation where there is urgency of the time. You need actually to intervene now, and you cannot make assessments. You cannot actually test the capacity. This is the common law. But stretching the common law, there has been cases where the common law has been stretched, and the court, I'm going to come to that in a minute, the court has been criticized because they overstretched the common law to the extent that they can suggest everything can be done under the common law. But to be honest, in the Western societies, sometimes there is extremism in this area of autonomy. I don't know whether it is a sign of civilization or a sign of being quite exaggerative, but usually they actually make things difficult when it comes to autonomy, confidentiality, and these situations are examples. It's never actually, but I tell you some of my experiences. Okay.
Another thing, do you think that we are even the rules here in our countries is affected by Islam?
No.
And Islam, for example, does not allow a patient to take his life. It is not like the Western countries. So applying the Western rules can put you actually in danger here of maybe a neglect, because they will consider you basically neglecting the patient. So we need to take this in consideration also.
That's why at the very beginning, you need to understand the norms of your working place, the culture. But I would think in every case, get a ruling from the court. To your side, get a ruling from the court, just in case. For example, if this guy was Jehovah's Witness, was a Western guy working in United Arab Emirates, and you done this, there will be interest in so many kind of media organizations to make a lot of fuss about it. If you give him the blood transfusion, you did not respect the religion of this person, blah, 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 blah. So get the court on your side to be protected. This is, I think, what you have to do. Okay, we need to proceed quicker because we don't have much time left. Chronic schizophrenia, frequent admission to the hospital, frequent relapses. He has diabetes. Unfortunately, I come across one of these cases. And presented with psychotic symptoms, auditory hallucinations, and negative symptoms. And diabetic center contacted you. This guy has gangrenous feet. He needed amputation to save his life. And he refused. So what will be your next course of action? Advised to carry the surgery only with the consent from this family because he is clearly lacking capacity. How do you know that he doesn't have capacity? And again, if he lacks a capacity, it is not about taking consent from the family. No, the doctor will have to decide on that, not the family. Urgently assess the patient. This is in every situation, but in our country here, unless we have a mental capacity low, clear, we have to seek advice from the family. Urgently assess the patient and examine his capacity and rights to refuse medical treatments. I think this might be okay. Who is doing this? Is it a sign for me to speed up? Or?
Like 7 minutes.
I think I got 10 minutes.
10 minutes.
We started late. Okay. Right. Okay. We'll go quicker. All right. Then suggest that the patient has the right to refuse treatment for medical conditions and you cannot intervene surgically under the Mental Health Act. Leave him to die. Maybe not a good idea. You want to assess the patient. He refused the surgery because he believes that demons will come out of the amputated feet and kill his family. So clearly he's quite deluded about it. So how would you proceed? He is clearly psychotic and surgery will have to be performed with consent from his family. No, you can't do that usually under the Common Law or Mental Health Act or Mental Capacity Act. He is still be able to refuse treatment and we should let him leave the hospital. Not a good idea. Admit to acute psychiatric care and try to treat his delusion beliefs and to get him to consent to the surgery. That seems to be a good idea. This is what actually been done. Following acute psychiatric care, he continues to hold the same bizarre delusions. Consequently, he continues to refuse surgical treatment. Family are concerned about his deteriorating physical health. So what will be your next course of action? Give green light to the surgery as his capacity is seriously compromised because of his mental illness. Maybe this seems to be a good idea. Accept that the patient has the right to refuse surgical treatment and educate the family. Maybe not. Speak to the legal advisors. You may be able to get an advice. Apply for court review. Usually this is what people usually do in such situations. It's safer to apply for a court review, and usually they will actually agree under the Mental Capacity Act for the doctors to carry on the surgery based on him lacking capacity because of he will fail test of capacity because of mental illness. Right.
But Dr. Ala, does it take time for the court to give you a decision?
No.
Yeah.
No. Usually, in places, you can get the decision within 24 to 48 hours in certain situations. This is an on-call magistrate covering the clock. You can get actually a decision within the same day in certain situations.
And it is here in UAE as well?
No.
Okay.
No, here it would take a bit of a time.
Okay.
Yeah, hopefully we have not come across the same situation. I sadly faced a case, schizophrenia, diabetes, gangrene. I authorized his part amputation of the feet under I would say the lacking capacity kind of thing. They carried out the operation. He was actually refusing the operation, not because he was insisting. He said that, no, you just give me medical treatment. It should heal, wallahi. Believe me, doctor, it would heal. No need for the surgery. I don't want surgery. I don't want surgery. He had the surgery, and the following day he died out of medical complications because of a medical error. Believe me or not. And I felt very bad, especially when his mother came to me and I said that you didn't say anything about my son. See what happened to him? Then I felt basically very, very bad. I still do when I remember this. Right. I'll just give you a summary. Yeah, this is a situation, we call it revolving door in schizophrenia. Many people, they just have the medication in hospital, get out, no depot, no medication, relapse. Come back to the hospital. Then you knew about such a situation and the family asked you to get the community team to give the injection at home against his wishes. Can you do that? Give him the depot injection at home against his wishes. And they wanted you to do that after discharge from the hospital. He was still stable. Yes, he is refusing his treatment starting from discharge, but he is stable, but he is likely to deteriorate. Can you give the medication against his own wishes while he is stable? He's not actually psychotic at the moment. He's not putting himself or other people at risk. There's no criteria of the Mental Health Act you can apply here at this point in time. So what would you do? We had nothing to do when I used to work in the UK for several years, had a lot of suffering. We tried to come up with something. Finally, in 2007, the community treatment order came in place, a change in the Mental Health Act, and you can enforce, apparently, the injection on the patient before he relapses if you are clear that if you leave him, he will be putting himself and others at danger in the future. But you have to call him to hospital. You can't give it at home. For a short admission, give the injection, then he can be allowed to go back home. This is what we call community treatment order. This is actually, again, a very tricky situation. Disclosing 19 years old lady, depression, disclosing rape by a close relative. He was her father, apparently. And the mother is denying it. She came with her to the clinic. So what would you do? Can you inform the police? She's 19. She needs to do that herself. Ask the mother to observe her, may be a good idea. Call for the father and talk to him. I'm not sure whether he will be kind of cooperative. Try to get more details about family dynamics and what the patient wants to do about the sexual assault, maybe a good idea. To be honest, I think what happened at that situation, the lady was scared, history of sexual abuse, unfortunately, and physical abuse. She has been threatened by the father. If she disclosed anything, he would actually beat her up. What should you do in this scenario? Encourage her to talk to the police? Maybe you have to say, listen, if something starts to happen again, or if you want now, it's up to you, but you need to put an end to that. Call the father for a meeting and try to warn him this and that. This may complicate the situation. May say this didn't happen. He may complain against you even. You're going to create a scandal in the family. Ask for legal advice. Maybe consider that the patient is a vulnerable adult. She's coerced by the family, by the norms of society. She's a vulnerable adult. Maybe you can say that she actually, you can act on her behalf because she's quite vulnerable. You may have to inform authorities. Maybe people would say, no, she's an adult. You can't do that. Do nothing but see the patient at regular intervals. Believe it or not, this has been the decision. See her every week. Make sure that the psychologist will see her frequently. Follow up the case. Make her try to get her to be assertive, to be able to say no. And if this was not enough, say, I will support you if you decided to go for the police. That situation, again, is not unusual, but it is a very tricky also situation. People may have different opinions by this, but to be honest, because of the autonomy and confidentiality, and because what you expect from the family to do against you, maybe this is the best course of action, just to keep a very close eye on this lady, work with the mother, and try to prevent further abuse from happening. Other kids at home, if there are kids at home, you have obligation to inform authorities. You cannot actually say, no, I wouldn't. You have obligations. Yeah. No. I will finish by giving you this last scenario. I skipped many of the scenarios. This is a scenario I faced myself many times in the secure unit in the UK. 36 years old man admitted to medium secure unit in the UK under the powers of the Mental Health Act to be treated for personality disorder and pedophilia. He was transferred to the unit from a local prison. He was transferred because they wanted him to be subject to sex offenders treatment program in the unit. They have programs like sex offender treatment programs, focus on pedophilia, focus on rape, focus on this and that. Psychotherapy sessions, basically. In addition to small dose of atypical and psychotic, maybe to help him, he's had personality disorder, help him to feel less agitated and this and that. He continues to fantasize about having sexual intercourse with underage boys. This is a psychologist is telling you so. Mental health review tribunal, usually people detained under Mental Health Act, they will have to be reviewed at a short intervals regularly, but a body called Mental Health Review Tribunal to make sure that their rights are preserved and you're not detained without good reason. And you as a psychiatrist, we have to provide the evidence that the continuity of detention will have to be in place. The tribunal has the power to discharge the patient against the wishes of the treating doctor, but he will have to listen to the reasons given by the doctor that this guy needs to stay under Mental Health Act. The Mental Health Act tribunal refused to discharge him because he was considered to be dangerous. His treating psychiatrists make a deal with him. He suggested that he can be treated with anti-androgens, sibutramine acetate. It is chemical castration, basically, given to the patient so that they may think it will actually minimize his risk, although it wouldn't. Anyway, and to reproducing his sexual desire and would give him a chance for discharge. If he taken that medication, this is what explained to him, he would be more likely to be discharged, and this will actually give you a chance of, you can be discharged from prison after in the end of your sentence, but if you go to a secure unit under the Mental Health Act, you can actually stay 20 years under the Mental Health Act. It happens. So a sentence is much better than being in a forensic unit in the UK. So the patient consented to the treatment only to have a chance of release, but he was very upset about it. Would you consider this a valid consent? This issue. Last statement, what do you think of this scenario? Do you consider the patient consent to receive the anti-androgens and informed and valid consent? Do you agree on giving him the medication to help minimize the risk to children? Do you think this is ethical to give him anti-androgens to make him basically chemically castrated because of his risk? Do you think giving treatment in such a way is legal or ethical? I don't know. I personally didn't think this was ethical, but it is a practice in many of these secure units with people. And I remember one of the patients said, "Doctor, the problem is not here, it is here. Give me whatever you give me, it's not going to change. I have it here. It's not in my testosterone, it is in my mind. So there's no use, no value." Thank you very much.
Thank you very much, Dr. Ala. It is very, very challenging. And I believe each one of us was putting himself in the situation, and we can imagine how it is difficult to take decisions in such cases. Any questions for Dr. Ala, please?
Thank you, Dr. Ala. I'm Dr. Ramzi from NRC. I would like to ask a question, please.
Yeah.
Is it legal in United Arab Emirates to engage family for collateral information against patients willing? Thank you.
Thank you.
Yes, I mean, I think you shouldn't collect collateral information without the patient wishes. In most cases, the only excuse, if you're going to go beyond the confidentiality, there should be a clear evidence that lack of such information will put actually the patient or a third party at significant risk. But I would advise, I mean, I'm sure we all know that, we will try to work with the patient without kind of creating a situation which may not help him to engage with us in the future. But to be honest, in our practice, we don't actually, I would say, care about the details, which is not really good. But ethically speaking, you shouldn't actually without his consent. But to be honest, the situation can be very bad when it comes to drug misuse. He will tell you his version of the story, and you are left in the dark. Certain situations, you need to know what is happening in order to structure your management plan. You have to use your judgment whether this piece of information is vital for the health and safety of the patient and the others. If not, maybe you shouldn't. But if you did, I don't think you're going to be liable by the mental health law or the civil law here, I can tell you from my experience. But he will be angry with you. The family wouldn't be bothered, to be honest, in most cases. But you have to make that balance yourself. But as I said, it is illegal to disclose information without the consent of the person. And the person will sign a form that we cannot actually share information or get information. The only way, as any children, I'm sure we know that you can actually get information from wherever with the consent of the parents. You can contact school with the consent of the parent. You cannot do that without the consent of the parent. To contact school, for example, to inquire about patient behavior or performance or whatever. Again, the common law. The common law does not apply usually in situations where there is no urgency. Okay, does not allow. Law of necessity applies in situations there's a sense of urgency. Somebody, for example, in the hospital, and you need to give an intervention right now, the resuscitation, for example. So there's no way you can assist, no way you can consult the family. You have to do it right now with a law of necessity. Somebody in the ER, you need to do an intervention, take up a sample, do what? This is law of necessity. But you cannot stretch the law of necessity to a situation like this. You have to use the regulation regarding confidentiality or Data Protection Act, whatever, if we have an act like this here. But it all stems from what you patient signed on admission and according to rules and regulations of your hospital. And basically, you wouldn't be in great trouble if this happens, but the patient wouldn't be happy. But I don't think you're going to be sued for it. It's not going to succeed if you have a good reason to say this is actually was for the best interest of the patient, for example. You try not. Okay.
Thanks, Dr. Ala, a lot for your informative lecture. Dr. Hussein Shahouri from Psychiatric Hospital, Bahrain. I have just a small inquiry about, you mentioned about a test that you are applying in the committee when you decide about whether patients are able to manage their finance. Am I right about that? Or
yeah.
Just I want to know about it for curiosity.
It's not about
say.
Yeah.
Part of also
a
medical commission there. And we are facing a challenging situation. One of them, for example, we have a schizophrenic patient, and the father raised a case that she is not able to take care of her child. The issue that we know that if she is on treatment, she becomes extremely well. But the problem, she has a poor insight, and every now and then she will stop treatment, and she will relapse. And when she relapses, definitely we know that she's not taking care of her children. And we were in a situation whether to actually say that she is able and give her the chance, and this will improve maybe her compliance and adherence to treatment. This will encourage her, and we emphasize on that. But despite we emphasize it, she adhered to treatment maybe for 6 months, then she stopped, she relapsed, and just recently admitted to the hospital. So this is a challenging situation. Thank you.
Right. I mean, that's a good question. I mean, when I mentioned a test, I mean, I meant the capacity test for the people with a guardianship order, like make sure that he understands the extent of his property. He actually can, for example, assess the claim of the relatives. He knows the relatives in question, okay, and he is not subjected to any emotional or kind of pressure. This is for the ability to manage his own finance, whether he needs a guardian or not. In that situation, we have come across similar situations. I'm sure we all try to be on the side of the poor lady. She has a schizophrenia. Try to get her to kind of have the right to look after the children. So in that situation, whether she has the capacity to act as a guardian or as a carer or as a mother for the children, or if it doesn't. The capacity, as mentioned earlier, is a probability test. So you both actually, on one side, what will be in favor of her taking. For example, she's sincere when she's well, she's well. She has actually good emotions. She has a caring when she is this and that. When she is, for example, in a relapse, many mothers, they look after the children, they still at home and they relapse. They have schizophrenia. They didn't lose. But when there is a man in that equation with a court case, usually we look into whether she can, but many mothers, they manage to bring their children while they're having chronic mental illness. When she is in a relapse, we put what are really concerns us, 1, 2, 3, 4, 5. What we can help with if this happens, the hospital may be able, for example, to social service can actually step in. There is a family member, an aunt or an uncle, he actually agreed, and his name, this is to give some support to his sister, for example, when this happens, so he can actually give. On probabilities, there is actually more reason to say she is capable and less reason to say she is not capable, and you can prevent the evidence in such a way, unless you are very concerned about her ability, or maybe she's going to risk her kids or whatever, then that's another story. But I would actually put what is with, what's against. I try, if I want to help the lady, I feel that she deserves to be helped. I maximize the with areas, with solutions in case she becomes. And maybe I can make a contract, a deal with her that you will actually be given that privilege if you stick. Maybe I will refer her to the community team. We have a community team, for example, in Abu Dhabi, where people can visit at home. So basically, it is a capacity is not an all. Yeah. So the capacity as it is. Yeah. The capacity is not all or none. This is the point. The capacity is about probability, and basically, a person can lose capacity in certain areas and have capacity in different areas. So it's better to put the sensibility. We call it. It has a name, but I forgot it. A sensibility test or something. Just put what's against. Try to make the balance. Present it to the court. On basis of probabilities, I would go for that she can blah 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 blah. And take it from there. And if she proved not to be, for whatever reason, you may have to reconsider your decision in the future. Thank you.
Thank you, Dr. Ala. I am Muhammad Hassan, consultant psychiatrist at SKMCA. Actually, I'd like to share an experience and to know if anyone has been through this before, and if he can share his thoughts and inputs. I have received a patient with mental retardation and who's been sent by the court. And the question was whether his illness is transmissible to his offsprings, and based on this, whether the patient is fit to get married or not. So anyone has any experience with any case like this? And what do you think of the?
Sorry, I think I would say this is a very strange question from the court. I have not come across a certain situation. I don't know, Dr. Amani may remember, but when it comes to mental retardation getting married, okay, if we apply the ethical laws, the capacity law, nobody can consent on his behalf for him to get married. Can it say his father will sign the contract? This shouldn't be the case. Can he sign the contract of marriage? Possibly not. He may not be, has a significant learning disability. Maybe he is not actually capable for signing a marriage contract. A marriage contract by the mental health law or on the civil law in relation to psychiatry, the marriage contract shouldn't be signed except by the patient, by the person himself. And if the person does not have capacity, للأسف يعني إحنا بنقول he shouldn't be get married. ده السؤال من أساسه خاطئ. نمرة 2 طبعا ده ما بيحصلش. أنا شفت ناس عندهم learning disabilities مجوزين ومخلفين ب IVF. طبعا حاجة يعني do you think this is ethical؟ أخلف عيال في الدنيا وأخفض عليهم من الفازر يكون severely learning disabled وأخلفهم بالطريقة دي، هل ده يعني صح؟ يعني حتى هو مش داريان بيهم يعني. ده طبعا مش جيد. السؤال الثاني يعني إذا في مش يعني genetic abnormality، والله يعني الكورت، هل احنا وصلنا لمرحلة ان الكورت بتحدد اذا كان هذا الانسان، لو احنا افترضنا انه من حقه الجواز، افترضنا ذلك you think he has a right to get married. well, I doubt this is true to be honest. Do you think we have the right ان احنا to sterilize somebody؟ يعني نقول له مثلا can you do that؟ this has been happening in the German era with Hitler. He's sterilizing people with learning disability, with mental illness, schizophrenia, even people who don't look nice, whatever. This is the road to exclusion بالطريقة دي. يعني حكاية إن هما if he is definitely going to pass this, so this equal to he not allowed to marry, it shouldn't be looked at in this way. I think what should be looked at is this guy capable of forming a family, looking after his kids, looking after his wife. Is it a good idea for him actually to get married؟ هنرجع concern تاني sex in learning people with learning disabilities. قصة كانت مصارعة في انجلترا. قال لك طب هل احنا نجبرهم على ان هم ياخدوا نعمل لهم sterilization عشان مش عايزين يخلفوا لنا عيال، ما يقدرش ياخدوا بالهم منهم؟ طبعا هناك العلاقات ممكن تكون مفتوحة. هل مثلا يعني نسمح لهم ان هم they have sex مثلا؟ طب وهل لو سمحنا لازم نعمل حسابنا انها to impose on them contraception ولا لا؟ فالموضوع ده is a very complicated subject. بس يعني I could be wrong, but my view is انه the question itself in the very beginning is a wrong question يعني. والكورت مش من حقها انها تطلب يعني والله لو هم طلبوا منك وخلاص. طبعا ما تقدرش تقول لهم كده يعني انكم انتم مش من حقكم كده وكده وكده وكده.
Actually, just to update you on the case, actually I have consulted the intellectual disability department in Al-Amal Hospital, which is headed by a very qualified intellectual disability psychiatrist.
Good.
And his advice was to respond according to the question and to assess the patient. If there is a high probability, for example, if the patient is known to have an illness that is known to
genetically
be having high probability.
Yeah.
So in this case, you can advise that, you can write that there is a high probability to transmit the illness to the offspring. Mm-hmm. And if there is no, you do the opposite without advising on.
Absolutely.
Yeah.
Absolutely.
I think this was a very wise
you shouldn't
decision.
Comment.
And this is what I did. And the patient
absolutely.
was successfully get married. I don't know what to say, unfortunately or fortunately. And I have been invited to the wedding by the Thank you.
ما عزمتناش. والله يا جماعة أنا يعني I don't know يمكن maybe I'm harsh on that ولا هل أنا فعلا denying somebody his right to form a family. بس بتهيألي أنا have to look into the wider picture, especially the kids in the future وكده. My learning disability should be okay, but significant motor-related disability أعتقد that's a bit too much يعني. Anyway, الله أعلم. ما أعرفش الشرع ماذا يقول الشرع في ذلك. هل يعني من حق الشخص اللي عنده يعني مسمين معتوه مثلا إن هو يتزوج، هل من حقه إن هو يوقع مارج كونتراكت كويس؟ هل من حقه يتجوز ويطلق ويتجوز ويطلق؟ هل يقدر يعمل كده؟
عفوا دكتور، شروط العقد المفروض يكون العاقل البالغ، إذا العقلانية هاي مش موجودة فكيف حيتزوج أصلا؟
ما هي دي القصة.
طيب
يعني
هو إذا العقل مش موجود، إذا ذهب العقل، إذا ما في زواج، إذا لا يصح.
ده معنى كده إن معظم الرجالة المفروض ما يتجوزوش.
لا
فما بالك بيتجوز مرتين وثلاثة وأربعة. معاك يعني this is what I see it يعني. للأسف في ناس عاقلين جدا ونفسهم يتجوزوا وما يتجوزوش، خلاص عادي يعني، مش لازم الناس تتجوز يعني، فاهمة؟ طيب شكرا جزيلا يا جماعة.